for Norfolk and Waveney CCG. It is a meeting in public. It's not a public meeting as such. There's opportunity for people to ask questions. I think we certainly have at least one person externally for attending this meeting this afternoon. So welcome. We have apologies from Peter Taylor from Healthwatch Suffolk, Thomas Aaron from NHS E&I, the LMC, and Kath Byford. I haven't got any other apologies. Have I missed anybody? Nope, I think that's so those are the apologies. There weren't any chair's actions taken between the last meeting and this current one in part 1, so I have nothing to report. Can I remind everybody to keep their register of declarations of interest up to date, including close family members? Are there any declarations of interest that anybody needs to make this afternoon in relation to papers? I take silence as no, so thank you for that. On to the minutes of the last meeting. I wasn't there, so I'm slightly handicapped as to whether it's an accurate, but I'm sure Hein will shout out if there is any inaccuracy. So can I just ask whether there are any inaccuracies or clarifications that people want from last month's meeting that Hein shared? No, so I would take the minutes as approved, and there's nothing arising that's not covered in the papers later on this afternoon. On to the action log. The first 3, no more than that, I want the first 1, 2, 3, 4 are flagged as blue, so they are actions are closed. The next one about number 99 is on LD Health Check. I think we have a paper this afternoon. Yes, we do. So can I take that as is that covered in that paper, Shepherd, the patient user, or is that's going to be in May's agenda? So we're going to keep that open until May about patient experience, because that's not covered on today's paper. The feedback to the CQC following last month's meeting about the positive impact, the letter has gone out to the CQC. Thank you, Shepherd, for crafting it, and I put my name to it, and so hopefully that will be some positive feedback from the CQC rather than usual negative feedbacks that regulators get. It's good to share some good news for people. So thank you for the team for that. And there's an item on HOSC oversight and the interpretation service. There is an update on that, so we can close that one as well, can't we, Sadie? That's in the papers today. Yeah, so we can close number 101 and 102 because it talks about a briefing note, but that's included in this afternoon. So we only have one item outstanding that will be picked up next month in terms of learning disability, health check, and patient experience to carry forward for next month. Excellent. It's always good to clear the decks between meetings. On to the forward planner. Thank you for updating the forward planner to include the meetings until the CCG disappears into an ICS. So that's very helpful. So we've got the set out for April, this meeting, next meeting, and the last one in June. Was there anything you want to add, Sadie, to that?
No, just that you can see a couple of items have remained paused for now, which I hope is okay by members. But obviously, if there's anything that people would like to see that we don't pick up through the normal meetings, then please do get in touch with me outside of the meetings, and we will have a discussion about that with Doris.
Are there any questions to Sadie on the forward plan as presented? We're happy to accept it for the work plan until beginning of July, end of June. So rapidly on to the risk register. Do you want to take us, highlight anything, Sadie? I just, before we start, I think there's just a comment, I think for me, was about whether the document needs a bit of a refresh, because some of the risk, the assessments have they're probably a couple of months out of date, or so it might be good. It would be good to get a refresh, especially on the high risk items next time. But over to you. Thank you, Sadie.
Thanks, Doris, and thanks for that comment. And you might spot that as well, that the majority of the risks have been updated as at the end of March, but there are one or two that have already started into April. So we'll sort that one out as well, to make sure that we are consistent across all of the risk owners. So I'm going to assume that people have read through all of the updates highlighted in red for your convenience today. I've just got 4 or 5 to comment on, if I may. PC3, which is the locally commissioned services risk. As you all know, the project is largely complete now. There are just a couple more items that we're working on around mobilisation, and there will be an update in detail on that in the private part of the meeting. As such, we feel we're able to reduce the risk level down on this to meet the target risk that we had in place for this this particular entry. So we'd like to propose today to close the risk, however, continue to monitor the mobilisation at the next 2 committee meetings, so that the members can just be continued to be kept updated on that. And obviously, if anything arises as part of the mobilisation of the last couple of elements, we can think again about whether a risk needs to be re-entered. PC6, learning disabilities, is also one of our high risks. I don't propose going through that now because we have a paper on the agenda. The two, we have a PC9 is the hypnotics and anxiolytics risk that remains very high, but Michael no doubt will update us on that through his prescribing report later on the agenda. Again, PC11 is our interface risk. We have got a paper on the agenda today as requested. Unfortunately, Lois has been unable to join us, but Mark chairs that group, and he's going to present the paper in Lois's absence. And then finally, PC14, which is also on the governing body assurance framework, remains stubbornly high risk. We have seen a number of changes at the end of March. For example, the Winter Access Fund has finished, and we're just completing the final claims for that now. We are proposing a change of date on that risk, which was due to come to an end at the end of March, because of the ongoing impact of COVID, and we are seeing quite a significant impact on practices as a result of COVID-related sickness absence. So I think, you know, there is no change to the scoring, and we probably do need to keep quite a close eye on that over the coming months. And as we transition to whatever governance arrangements we have in the Integrated Care Board. But I think that's probably all I would like to just highlight to you, but obviously very happy to receive questions.
Thanks, Sadie. Chris?
Yeah, just a quick one from me, just on the couple of meds management risks. I just wonder if that can be enhanced so that some of the actions the more specific actions that Michael and his team are taking to work with the practices. Obviously, it says they get their data and they're looking at it, but I know that probably behind the scenes there's an awful lot of work Michael and his team are doing. So I just think that might help enhance the risk. I don't know what the view of others are on that.
Hein?
Thanks. On PC15, it's the Wave 4B primary care hubs, and I know probably will be covered in an update later on, but if I read the comments in March and April, it looks like the risk has gone up. So my request to Sadie and the team is for next meeting, maybe incorporate the latest insight, and I believe there's an important meeting next week which will provide some insight. So it's more a forward look request for an update, reviewing that risk. Thanks.
Thank you, Hein. Doris, may I come back? Well, I will liaise with Michael outside of the meeting about the helpful suggestions from Chris. I think that's valid, and we'll certainly do that. Thank you. With regards to the estates risk, having had Hein's comments, I can see that the box is the wrong colour. So that is why I haven't highlighted it to you. Paul, I think do we have estates later? Yeah, we've got estates later on the agenda. I think it would be really good to discuss your comments under the agenda item, Hein, when Paul is in attendance, and then we can take action accordingly thereafter.
Yeah, I think I would agree with Hein, because it's given the red rag status, it just doesn't look quite right. But we can have a deeper discussion later. John?
Yeah, just to comment on that point, so as you say, it'd be good to pick up with Paul later, but I was party to a meeting with the NHS England regional team last week and reps from the national team who were part of the governance process for the business cases that we're going through, and they were supportive of the approach that we're taking, and there's been really good liaison over recent weeks and months to make sure that actually we are all aligned now in terms of the process that needs to be undertaken. So whilst there's still lots of hurdles to get through, that felt a positive meeting last week, certainly.
Thanks, John. Tracy?
Yeah, just going back to look at the number PC14, impact on practice from the COVID pandemic. I think it's good. It is right to extend that risk for longer, but I think it's kind of, we are at a time now where we would expect it to get slightly kind of capacity in primary care to be better, and it's not. It is more kind of pushed, and I'm certainly thinking during the summer months we'll have, as we always do, you know, that holiday period to consider, which is going to be increased pressure. And I think the unknown of what next winter will mean in respect of COVID vaccination boosters, and again the impact on primary care. So I can see that extending at the moment, really, and we've really got to think about that kind of workforce there as well, haven't we, into that risk and what our workforce plans are.
Thanks, Tracy. I think it's sensible to extend the the date on that one, but at some point, we do need to live with COVID, whatever that is, in the context of the NHS, and in the context of the wider society as well. But I think it's to be discussed at a future date. Thank you. Are there any other questions or comments for Sadie on the risk map? No. Thanks for the update, Sadie, and look forward to a refreshed version next time. Thank you. Moving on to the Learning Disability Health Check, item 7 on the agenda. Shepherd.
Thank you, Doris. Just to say it's good timing. I think I can hear some banging and probably fixing things from my neighbours. That is stopped. Thank you. This paper is for noting in terms of the progress of where we've come from and where we are now. I'm really pleased that we continue to make progress month on month. So I just want to highlight the progress since last month. So you would have noticed that we are now at 54% at the end of February period, which leaves us with the March period to anticipate our position for end of year. I think it's going to be a close call to the end of the year. I think we're looking at possibly just about there. We'll confirm the position next month once the data has gone through the validation process. And I think I would like to say we are now focusing on the following year. And with that, it gives me probably courage to say the risk that we have been working on in the last year, I don't think it will be the same the following year. So I'm expecting that the risk score for learning disabilities should change in Q1, but that will be confirmed once we know our final position. And the reasons for that, I think, as you can see in the current kind of focus section, clearly there are game changers in that. So we have dedicated resources across all our localities, and we are engaging with our practices quite actively. So this is going to change where we sit in terms of what we are doing for our population, as well as our position within the wider system in the east of England and across probably the country. I'm quite encouraged. We received a contact from NHSE interested in having conversations about the initiatives that we have started. So they are joining our delivery group next month to go through some of the initiatives with a view to share their own experiences from other systems, and for us also to share our experiences. In terms of probably data or performance, which is at the bottom of the page, you would notice that Great Yarmouth is sitting in the lead in the table, and is just to be observed in some ways, and it's quite encouraging. And you would also notice that all our localities are well above 50% now, which is good evidence of a lot of hard work that has gone in particular in the last quarter. So it's really looking positive. I will probably stop there and ask colleagues for any questions.
Thank you for the update, Shepherd. It's good to see progress, but I suppose the flip side is, even we hit 75%, what are we doing about the other 25%? But that's the challenge we always will give you, I suspect, in terms of addressing inequalities in Norfolk and Waveney. And I'm sure Tracy will pick that one up too. Tracy.
No, I mean, it wasn't about the missing. Obviously, we always want to get the missing, but to me, it's great. I mean, it's really good progress. It kind of has been kind of fitted in that last quarter, but it's a question about the quality of the health checks, because we can do them, we can hit the target, we can tick the numbers, but are they a good health check? Is it a good quality health check? What's the feedback from the families and the patients? So that's my question, because I noticed we're looking at an independent specialist provider. So are we assured of the quality of those health checks? So to me, it's about the quality of them, that they achieve the outcomes that we would want, and they are a good health checks. So that's my question really, but really great progress, good to see.
Thank you. And thank you for bringing the quality aspect. And we are very, very clear that quality and the numbers should go hand in hand. And we have the quality team actively involved in every kind of opportunity that we have. They are part of the delivery group, and that delivery group, the plans going forward in the new year, it's co-chaired by quality and commissioning. All the external resources that we have put in the system, they're going to have the training with our quality team, and they also have the checkpoints with the quality team. we've learned quite a lot from the work that we did in Norwich, and that needs to filter through into all we are doing to going forward. So I'm confident that our quality will improve as well as the numbers improving, because there's huge interest from everyone that what we do matters to the patient. And I think we will test it together at the next meeting, because that's where we are going to bring patient stories, because I'm really keen that we start talking about patients rather than numbers. I think the numbers seems to be going in the direction that we want, but I want to get a good feel of how families and people out there are experiencing this. And it's going to continue to improve month on month as well. So yes, so I take the challenge around quality.
Thank you, Shepherd. Bill.
Thank you, and thank you, Shepherd, for your update paper, which is very good to see the progress that's being made. In current position, you just make a comment. The board is asked to note the current pressures on primary care and the potential impacts on delivery. Is there, is that going to have a big impact on the year-end figures, do you think?
I think the current position in broad sense, so workforce issues and also where we were with the pandemic, we won't reach where we could have potentially reached if we didn't have those factors built in. But in terms of hitting the 75%, it's a close call. It's going to be tight. Yeah.
Thanks very much.
Hein.
Thanks, Shepherd. Good update as always. My request, when you mentioned the new year starts, but could we somehow keep track that we ultimately get to the 100%? I've always found if we start counting afresh, we never know whether it's maybe always the 20% we don't reach because they're harder to reach. So is there something you could help in your or support in your reporting that we can see that actually those 100% are ultimately reached out to? And then another question, maybe you can include in your next month's report. I read somewhere in the pack that part of the health checks are done face-to-face, but some are done non-face-to-face. Could you share a rough statistic next time? How much is face-to-face? How much is non-face-to-face? Thanks.
Absolutely, I take those points on board. And I would say we are working on 100% operationally and in terms of our registers. But I think just for assurance purposes, in terms of the national targets for this body, that's why I made reference to 75%. But that is not what the delivery group works on. It works more on 100%. And one of the priorities for next year is looking at DNAs, which is those people that have not turned up, and we've started some work in West to actually identify those and assign resources for that. We're really thinking quite hard around the prioritization and redistribution of how we do it in the new year. So there's quite a lot that I know when I'm giving in this update. Sometimes I feel like I'm not representing enough the hard work that is happening on the ground, but I'm sure I'll continue to improve and get that one to the members.
Shepherd. John?
Yeah, thank you. Just a quick point on numbers, I suppose, Shepherd, and echo what others have said in terms of the good progress. So just looking the last couple of months, I think in January we did about 600, in February we did about 670 by looking at the numbers. And I think the average we would need to do every month to deliver the target is about 570. So the last couple of months have been above that average. The concern we've always had going forward is that there's the big rush at the end of the year and then it drops right off, isn't it? And recognise what you said about trying to make it sustain. So I think the reporting would just be useful to see those monthly numbers as well, so we can see if they're staying higher or if they're just kind of plummeting when we get into the new year. It's be useful to have that check as well, I think. Thank you.
Thank you. Are there any other questions for Shepherd? Thanks, Shepherd, and look forward to a newer and even better report as we go forward. But it's really good to hear that, you know, there is a lot of work going on behind the scenes, and yeah, I know you are probably sometimes a bit frustrated you can't share all of it, but maybe sometimes we can just do a spotlight on something in particular that you want to highlight as part of that reporting as well. But look forward to next month's report, including the patient experience and the family's experience. That will be really interesting to hear. We move on to item 8, which is the update on the Norfolk Health Oversight and Supervision Committee and the British Sign Language. Fiona?
Thank you. I take the paper as read, but I think we had a very positive discussion with HOSC on both papers, and it helped to highlight the pressures and challenges being faced in primary care around access at the moment, but also I think highlighted the areas where improvements need to be made. And also we're extremely grateful to our 2 clinical leads and to the LMC, because they were really able to tell it how it is on the ground, and how it's actually impacting general practice, and how what it meant for them in terms of access for patients. I think we do acknowledge that there's a lot of areas for improvement, and obviously we'll be taking that forward in our plans for this year. We are already working with our comms team to develop plans to go out to the public to explain the different roles in general practice, and that's very imminent. And I think that will hopefully help people to understand how general practice operates. And also the workforce plans, which obviously are a critical part of in terms of contributing to access. And then importantly around health inequalities and those patients who can't currently access general practice, or those who face greater barriers. And obviously we want to work closely with our colleagues at Healthwatch around this, and some of the continuing concerns, particularly around digital technology and how that impacts individuals who don't use it. And we're starting to see the comments come through around that, and obviously just really highlights some of the challenges that we're going to face this year if we're going to provide equitable access for everyone. But I'm happy to take questions on the report.
Thank you, Fiona. It was a really good summary of the discussions at HOSC, and it was good to read it. Thank you. Hein.
That's more a comment. So thanks, Fiona, for preparing the note. I watched the video of the proceedings, and I think it's all captured very well. I would echo what you say. It was helpful to have a number of GPs who could provide sort of real life examples to underpin the story that was conveyed. So many thanks for that. I thought it was useful to bring this back, given all the effort that's gone into preparing the material. Thanks.
Are there any other questions or comments, Fiona? No. So thank you for preparing the summary. It was very helpful. So we will move on to the digital update. I'm a bit ahead of time. Sadie, do I need to move things around?
Yes, please, if you don't mind, because we're waiting for Pete Ward to join us.
It's fine. I always like to, give us all a bit of a challenge when I had to do a bit of juggling. Shall we? We'll move on to item 10 because Shepherd's with us. So Shepherd's just disappeared from my screen. I think he's here somewhere. On the timeframe for the resilience funding, so we move on to item 10, if that's possible, please, Shepherd.
Thank you. I'll probably just need a few seconds to get to that paper.
Page 48 of the pack.
Yeah.
I think you seem
What?
ranging.
So while I'm doing that, it's just to confirm that this paper is for approval rather than noting as seen on the agenda. Again, I should start by expressing I'm really excited and happy about where we are with our resilience process and last year's position. So as stated at the last meeting, we were successful in distributing the resilience funding to all the practices that were successful in that bid process. And now what we are looking for is to share with you the learning that we drew from last year's experience and set out our proposal for the coming year to strengthen the resilience work within our system in Norfolk and Waveney. So in terms of the lessons that we learned and the feedback that we've received. So last year, our process kicked off later in the year, and it coincided with the winter pressures, and that had its own complications. And probably there's something that we would need to observe and learn from that. Then I think the other aspect of that period is that it coincided with the Winter Access Fund, and we were able to work with colleagues managing that area. So there are some benefits and also some aspects that we learned in that. And some of the feedback we received from colleagues from LMC and also from practice was around the time frame or the closing times for the applications, that they were probably shorter than expected. So I will reflect that in our probably recommendations or proposal going forward. And I really enjoyed being part of drop-in sessions with practices to talk about resilience within the system and the funding that we needed. So that's something that I will talk about again when we get into the proposal section, but it was really good to have that direct conversations to hear from practices. And also being part of the funding panel, it was really a great experience actually focusing on how do we improve or support bids to improve patient outcomes. And the scoring matrix was also an area that we tried to implement, and there's some learning that comes with that, and some thoughts about how do we improve that going forward. So those are some of the highlights from the lessons that we learned from there. But I now want to take you through the proposed GP resilience funding process for this year, which is 2022-23. So what we are really keen at is to avoid the busy winter periods, and clearly that will help us to be able to prioritize and to get in there early with practices. So the proposal is that we open our resilience funding process in this quarter, that is in Q1 of this year. And we are really keen that we have a good reach to our practices by giving them more time than we did before. So instead of 4 weeks, we would like to extend that to 6 weeks. So that would allow the conversations, the thinking, and the engagement with practices. The application form will need to be simplified and become relevant, and to really help us to get to the core issues that we need to be addressing for patients' experiences. And we are looking at developing a dummy application form which provides some guidance in it, with a very clear parameters set out on what can be included and what cannot be included in that. Practices have also asked for case studies highlighting the outcomes and the impact of previous year's funding, and those that feedback has been echoed by colleagues from LMC. So we're looking to do that. Then again, we're really keen that we engage with practices. We are aligned in understanding the issues that are affecting our resiliency within our system, and learning from last year. Whilst the drop-in sessions were very successful and well engaged, there's something about how do we bring the system, including states digital training, because those have some bearing on resiliency in their way. So I guess resilience, we learned that it was relative to individual GP practice. If we strengthen one part, we'll also strengthen the other parts. So I hope that kind of makes sense what I'm trying to bring out there. Then the assessment of bids and allocation of funding will go through the funding panel in the same way we did last year. We spent a bit of time talking about how do we target, or how do we get the best value for the for the money? How do we bring different parts of our system to an equitable kind of position? So some areas are more impacted by CQC, and some areas have got other concerns. So we're looking to weight some of our allocation based on the soft kind of understanding, and based on the risk register, based on the CQC performance, and look at the COF achievement. So further work would need to be done with our colleagues to make sure that we are fair in doing that, because I'm sure there will be some challenges or questions from colleagues around that. And we are really keen to factor some local intelligence, that softer stuff that sometimes doesn't easily come through. We really did find it very helpful to have colleagues from locality, colleagues that spend more time working with the practice supporting, sharing some information as part of the panel. So those are the recommendations. We are seeking approval from members to kick off this year's funding resilience funding process in this quarter.
Thanks, Shepherd. Are there any questions for Shepherd on the paper? I had one question, was what happens if we're allocating all the funding at the first half of the year? What happens if the practice suddenly, in the second half, actually would benefit from resilience funding, but the money's gone? How can we continue to be flexible and fleet of foot, I suppose, to adapt to situations? And maybe there isn't an answer and they have to wait for the following year. But that was my question.
That's a relevant question. And that's actually a real question in reality, that if that happens, what do we do? And I don't have an answer to you to that, but I am mindful I've got my senior colleagues in the...
Sadie, did you want to come in?
Yes, and I can see Mark's put his hand up as well. So for example, we may have a practice that finds itself with a poor CQC rating. I think what we would normally do, regardless of resilience funding, is to work with and support that practice with colleagues from the delegated team, the quality team, and the medicines optimisation team, which tends to be where a majority of the issues are highlighted, to support the practice to put an action plan in place. Very often practices have independently also engaged additional external support to help them, recognising that they are independent contractors, and it is within their interest to address any issues. But I think it is a really good question, and we probably need to have a think about that in the context of how we invite bids, because we do know from the summary that we looked at last time that we have a significant proportion of practices that haven't had a CQC inspection since 2015, 2016. And we also know that we are working on but haven't yet implemented our practice visiting programme, which again will spot some of these issues, hopefully at an earlier stage. So I think it's a good challenge, and I think we can probably think about how we build that into the process to ask practices to have a think, and where and this is where Shepherd's comment around local intelligence comes in as well, because we do know now the issues that tend to get found at CQC inspections, and we can do some preparatory work there, I think, around perhaps getting a little bit ahead of the curve on this.
Thank you. Mark, did you want to come in before I come back to Bill?
Thank you. Unsurprisingly, Sadie's covered an awful lot of what I was going to touch on, but just to build from there, I'd say we shouldn't underestimate how much time that takes of our teams when these circumstances do arise. It is quite labour intensive to support. Obviously, we want and need our practices to be resilient and successful, but where we have done that previously, it does take a lot of time of our teams. Just something else to add as well, talking about more generally resilience for primary care. Given the pressures that we're seeing in our urgent emergency care system at the moment, we mustn't forget that 80% of urgent care is dealt with by primary care. So, you know, relatively small changes and pressures building in primary care have quite a big impact on our overall urgent emergency care system. So one of the things that we're doing as a team at the moment is we have what they call the OPAL. It used to be kind of red, green, and black alerts and things about, but now it's OPAL 1 to 4, 4 being the most extreme pressures in our system. But it's very difficult to judge what's the OPAL status of our primary care colleagues and primary care capacity. But we are doing some work now just trying to get that local knowledge, so we were able to explain and convey as a part of our urgent emergency care system some of those pressures we're seeing in primary care. So it's quite a live area for us in addition to what's been covered in the paper. But as both Shepherd and Sadie have said, you know, I think it's really important that we support but also present those pressures when we see them.
Thanks, Mark. Bill?
Thanks. Well, my first question was, is the pot ever spent out? And it sounds to me like it is from listening to the answers to the earlier questions. And I suppose that then comes, so if somebody puts in a bid that is acceptable, but is then turned down because the pot has been spent, is that a sensible use of the time of the practice? And what does that do to the people who are not successful? And also, is the extra waiting going to push out practices who are bidding and change their outcomes as a result? And in terms of obviously wanting practices to invest in improvement, do we have any built-in disincentives around the way that we're managing this?
Okay. So I think there are three parts to that, and just to make sure that I have fully understood. The first one is about a sensible bid, but that may be affected by the waiting in the event that maybe some practice may need it more than the other. just to check that I got that right. Then there was the last bit about disincentives. Do you mind to just run that again so that I will probably address you once on that?
Yes, I mean, it was just that if you have a perfectly good bid, but the money has been spent, isn't that a waste of the time of the practice? And isn't that a disincentive for them to engage in the process?
Okay. So that's a very helpful pointer, and I will take it back to the team as well to discuss that further. But my immediate response to that is that this is a process. And you would probably see from what we are proposing that this is not a one-off conversation. So submission of a bid is not, it's not happening in isolation. So we are going to have drop-in sessions to test out. We are going to have loads and loads of communication that gives information about what we are receiving in the system. And also there will be lots of signposting that is involved. So for example, it may be a sensible bid, but there may be where there is more money available, like what we have done recently. I think if not all our bids have been successful in some ways because we were able to work closely with the winter, the WAF money. So I think the dialogue proposal that we have with our practice and talking more with each other will help to manage some of what you're highlighting as disincentive in some ways.
Does that answer your question, Bill?
Yeah, I mean, it does, and I can see it's a complicated area. I suppose my, I'm not looking at the money, but I'm just thinking that if there's a criteria for a practice to hit and they hit it, then their outcome would be hopefully successful for them when they get the money. Or either the criteria has to be more difficult, or even so only certain types of practice can bid in for the money, i.e. the ones that are going to get the weighting, so that you then don't waste the time of the ones that are not going to get the weighting. Or you have it in tranches where you say these practices can try first, and then we can have another bidding with the next lot of practices or something like that. Just so that I think that there's more clarity about whether you're likely to be successful or not.
Did you want to come in, Sadie?
Thank you. I think Bill raises a number of really good points which outline the challenges that we've had in managing this funding over the years. This funding is always oversubscribed, as you would, it's, when you think you've got 105 practices and 143k budget line, we often get more bids than we've got funding. And we were quite fortunate in the last year because we did have other funding lines that we could direct practices towards, such as the Winter Access Fund, which we won't have. We might have it later in the year, but we certainly don't have it at the moment. And I think what Shepherd and his team have tried to do is to introduce ways of supporting practices in terms of understanding what is and isn't suitable as a bid, what a good example of a bid might look like, and trying to put that dialogue in place and the local intelligence. But I think it will be interesting to see through that dialogue how this goes down this year, and I think we need to keep learning from it, because we certainly have had that feedback in previous years, Bill, that what's the point of applying because there's never enough money to go around. That is feedback that we have had. I'm not sure that we've had it this year. I think it worked really well in this last year, the process, but we did have those additional budget lines to further enhance what we were able to do. I think it's a good challenge. We'll think about it in the context of the dialogue that we have with practices. We'll have a further discussion with the locality teams, and I think we will need to again just keep evaluating what we're doing and try and get it as right as we possibly can.
Thanks, Sadie. I just want, does the proposal need to go away and be refined, or can that be done as subsequent to any approval from the committee? Anybody want to take up the challenge of that one? Because we're not talking about a huge pot of money. I think that's part of the challenge, isn't it? Because it's a limited pot of money that's going to be only available to a limited number of practices to be effectively used, because you don't want to dice it up so much that actually the money is going to make no difference whatsoever to anybody, which would be the worst outcome. And I just wondered whether you wanted to reflect on the conversation before we approve anything. Or you're going to say, well, actually, it's not really going to change anything fundamental, and so it stands as it's currently proposed.
I think my personal preference, if members feel comfortable in approving it, would be to take it away and kind of build the comments into the process that we then published, and we will share the final version with the LMC if we do make any tweaks, and we can certainly bring it back for noting. But I noticed that other colleagues have put their hands up, so they may have a different view.
That's fine. We'll see where this takes us. James.
Hello. I just wanted to say if there was a chance of doing a sort of pre-screening easy way to see whether or not practice would be eligible would be really helpful, because one of the things that deters is the complexity of just applying and going through the whole process and it will fall on the particular individual, i.e. the practice manager, who is already stressed and all of that stuff. So it can be quite difficult to get your head clear when you've got so many other things to do. So it's sort of, if there was a way of sort of saying, yeah, no, I think we can give you something, or actually we don't think it'll be a chance. I just raise it. I mean, I've got that's all. It's just the individual impact in, because what happens sometimes is some bids are so complex you just think you've got no chance and nobody applies for it because it takes a whole day or a half day in an otherwise busy schedule.
Thanks, James. John?
Yeah, I was just going to say, I think James makes a valuable point there. I think that would be helpful, but otherwise, I would go with the process as it stands. The sense I have is that it's worked really well in the last year. I think I'll probably err on the side of caution of not deterring practices from applying. I suppose I'd rather have more apply and then understand what the issues are, and then also sometimes it happens that more money becomes available through whatever route. Last year it's the Winter Access Fund. There might be other things that become available in the future that we don't yet know about. So if we've at least understood through the process what the issues are that may need to be addressed, we can probably respond quicker to those. So it might result in some practices doing work that doesn't result in funding from the Resilience Fund, but I think it's probably still useful intelligence, but subject to the kind of pre-screening that James has mentioned.
Thanks, John. Mark?
Yeah, I would agree with that comment as well. But also likewise with James, is about we can't make this overly complicated and take up a day, 2 days to complete the process. Thinking about every year we're told there will be no money to support urgent emergency care resilience, and then inadvertently we're normally given a week or two or a day or two rather, to come up with what are your bids that you need to make yourself resilient over a winter period, for example. So what we have done previously is have bids in our back pocket, essentially, so that should, as others have commented, when funding isn't made available, we can move quite quickly. So if we could set something up, as James has suggested and others, that is not overly bureaucratic, but just that we have almost off-the-shelf things ready to go, that might be helpful, as John has said.
Thanks, Mark. I think that's a very pragmatic approach. Shepherd.
Thank you. It was just a small comment around that weighting, the thinking that is behind that. It's really addressing towards inequalities. We really want to be tackling health inequalities. And that would really help us to bring those deprived, disadvantaged areas. That was the thinking behind that. You can see most of our CQC troubled areas and poor performance around data, and those practices sometimes sitting in those practices at risk. It's more to do with those inequalities that are sitting. So there's that in the background in that. But I do take the point that there will be sensible bids from other parts of the system, but they may be sensible for that affluent or good area, but it does not help sometimes in addressing the inequalities, but it will help us with the knowledge and data around opportunities when we've got probably additional funds to be able to address those.
Thank you, Shepherd. Are the voting members happy to approve the proposal as currently set out? Yep, thank you. And no doubt if there is any significant changes, you're going to bring it back to us either for reapproval or for noting, depending on the amount of change. Great, thank you. Thank you, Pete, for hanging on, well, coming early and then hanging on. We'll move back to item 9 on the digital update. If you could just take the paper as read and highlight anything that you want to bring to our attention in the paper. Thank you.
Thank you, Doris. Yep, I hope you do. I hope you've enjoyed reading about digital. I'll just highlight a couple of the successes that we've seen. So I would highlight in particular around our M365 approach. Work being compiled, so all the practices have had their data migrated to the cloud, and the team will work on Tarin practice servers. So what this will mean is that ultimately GP practices will be able to connect and work with the rest of the ICS via things like single sign-on, better Wi-Fi, and that ability to collaborate through Microsoft Teams. And that will also enable staff in the additional roles to work more flexibly and productively, and all primary care staff will have that option of flexibility. The other piece around I would highlight around the cloud approach is the cloud telephony. As you've seen in the report, we've identified an advanced telephony supplier following a procurement. Now, what that gives us, with funded costs for that, is the ability to install an integrated solution that links up with clinical systems and can be used from any internet connected device. We've got 36 practices currently signed up, and the implementations are starting. And what that means is that practices can work at scale. They can hand things off between them and look at how they work together in terms of a shared front door, and manage peaks and troughs in potentially demand and how they manage that demand at scale and at working at PCN scale. The other piece to highlight is that we've obviously, due to the pandemic, a lot of things were frozen. So within that, we are doing a technology refresh, working in partnership with AGM for practices. So a full refresh is planned, and we are working with AGM, who are out to recruitment for those roles to fulfill those ambitions. What I would flag that we're aware of and we're working to support on is a lot of the concerns around where Footfall, the online consultation system, is being turned off. We are working with practices to understand that and support, and particularly look at how we can use social media to help with some of that. But that will be looking at providing to practices tools that help them in terms of supporting some of that demand management, and we will be engaging with practices on that very shortly. That's what I wanted to cover. Are there any questions, please?
Thanks very much, Pete. Are there any questions for Pete? I had one in terms of, I suppose, what we're going to do in terms of support for the deaf community, in terms of digital interface, whether there's sort of some work stream there to try and make it easier for them to access, primary care services.
So within the report, hopefully there has been a particular project around in primary care for people with a hearing impairment. So we are working with, we have been working with Healthwatch Norfolk in terms of that particular project and are looking more widely in terms of post-evaluation, what we could push out as an offer beyond just what we've done in terms of those vibrating pages that were trialled. And that was also utilised during COVID from an infection control point of view to avoid overcrowded waiting rooms.
But there are other sort of work streams within that to develop.
Yeah, so
That's-
building from that evaluation, Doris, that's what we'll look at in terms of what could be some of those other options in terms of digitally enabling and helping the patient groups.
Okay, thank you. Andrew?
Yeah, thank you. I just thought it might be helpful to give you some feedback from Healthwatch on the public's comments on exactly this. Just to outline in general, first of all, we're now getting back to seeing more people face to face for interviews with Healthwatch. There has been, as I'm sure you know, there's a footfall link from Footfall into Healthwatch, which means that a huge proportion of the comments that come in take advantage of that and are to do with primary care rather than secondary care and community and mental health and so on. So it does give a skew. And there's, sadly, of course, there's always a bias towards the negative on these type of things. And it's interesting, I think there's a wide spectrum sometimes about the same surgery, from highly positive to highly negative, and it's the same place. The main issue, I think, from the public is not access to clinical care, access to making appointments and obtaining information via either the phone or via Footfall or the other similar systems. So this is based on something like 300 odd comments, which I get to see them all, lucky me. There's good and bad, obviously, but the broad centre is that there's extremely long waits on the phone, and there's something wrong with the phone systems because people get very frustrated and they wait for 20 minutes or something to get an answer and then it cuts off. And I don't know what the technicality of that is, but that seems to happen frequently, and I've heard lots of comments on that, and I've heard that locally as well in my own local surgery. We have to contend with people's expectations, particularly, I think, older people, and this is just based on my, again, local conversations, but the expectation from a lot of older people is that phones will be answered within half a dozen rings, whereas what perhaps we consider success now is answering within 10 minutes or so. And I contrast that with I trying to phone my bank about something which took at least 45 minutes to get an answer. And then they told me it was the wrong number anyway, which is interesting. So what I do, I've picked out, if you don't mind, I'll just go through a couple of comments from some patients. So I've got 3, 2 negative, 1 positive, which is broadly the balance, but it gives you an illustration of what people are saying. So first one says, making an appointment online is impossible. Boxes to check in and out of, none of which allow you to make an appointment. Click on the box that says make an appointment and you still can't. I won't tell you which surgeries these relate to. The other one, another negative one, the website gives a loud and clear message. Go away. We are doing our best to make it impossible for you to find your way through endless and irrelevant information and prevent you completing the email form asking for an appointment. Positive one, extremely efficient, but extremely efficient, both face-to-face and phone calls when needed. It has allowed me to realise that I didn't need to see my doctor every time I had a concern, as it could be dealt with over the phone or via the triage system. And perhaps just a comment as well, just to say that from a doctor's point of view, phone calls are not easier or quicker. Phone calls leave you with more doubt as to things that you haven't picked up, and the fatigue aspect is to do with decision making. So it's decision overload, I would suggest, is part of it. And very finally, sorry to do this, but I did an appraisal with a DP yesterday. She gave me permission to quote her. Obviously, it's anonymous. Just so you all know, I'm sure you know this already, the post-COVID demand has been overwhelming, and we are in a constant battle to try and meet demand, much of which is unreasonable and certainly unsustainable, without drowning. It feels like firefighting a lot of the time. Everybody knows that, but I hope you don't mind me just quoting that because that's fresh in my mind from yesterday. Thanks.
Thank you, Andrew. John?
Yeah, thanks, Doris. Obviously, huge amount of work's been done on the digital agenda, as we get a brief overview in the report. And I was just wondering, Pete, if there's any kind of feedback from practices who presumably are seeing some benefits from the number of elements of work that you've described in the report.
So yes, some of that's been, I think some of the practicality that's come from N365 and that ability for how they can work and access data differently, because obviously before practices were all on single domains and couldn't necessarily work in the way that they did before. As they can now in terms of being able to share. I think we've also got good feedback, particularly around the cloud telephony piece, in terms of not only the value for money aspect of that, but some of that future functionality that will provide, and some of that needs to look at in a concerted way how we work with practices to help them around. And I know some of this is perception, but some of that demand management piece, and also thinking about what are those patient journeys before they hit the practice, and what can we try and do using digital tools to help sort of try and improve that. Some of that next challenge is identify working with primary care, and particularly around digital. We've got the digital interest group, which is well attended by practice managers and IT leads, and they're really supportive of a lot of the enabling type functions that happen behind the scenes, in terms of NHS giving them NHS mail administration rights and so forth, to enable them to create log-ons and so forth quickly. Just as an example, in terms of some of that's not new, that's just using existing technology differently.
Thanks, Pete. It's good to hear some positive impact that's had actually on practice with the changes as well. Bill?
I just wanted to say I thought it was incredibly positive that the platforms are now coming together. There will be a time in the not too distant future, hopefully, when everybody will be amazed that they ever managed before there was all this interconnectivity and that the practices could talk to each other, and that's hugely positive. I suppose the question is how do we get the laggards to adopt, so that getting the last 10% of practices into the system is because they're the early adopters and all the key ones, and they're all in, and when the PCNs come together. Is there a deadline, or is there a strategy to say we want to have X% involved, and then by this date we would expect you all to have done it? Or I didn't see that in the report, and if it's in there, I apologise. I just wondered where we're going to finish with this, where we're going to get everybody using these platforms.
Sorry, Bill, did you mean directly around online consultation systems?
Well, you were giving us percentages of the people so for example, with the telephony and with the PCNs forming their groups where they were all signed on, and I think it was around 68% or something. I just wondered if there was an ambition within the CCG that everybody would be signed up.
That would be an ambition. I think particularly around things like the telephony side, it's difficult to, that's an offer that's been developed, and we're not responsible for practice telephony. We're just trying to give an at-scale opportunity as much as possible to the practices. So that becomes more difficult in terms of be on the positive cells of getting more people signed up onto that, because that then does give the ability of, as hopefully I articulated, the that option of shifting calls between practices across PCN, so you might be able to manage it in that way. So there's some of the benefits that you can sell. In terms of the cloud strategy, yes, that will be 100% in terms of that being in terms of that virtualization, as it were, of everything, rather than it being on premise, to enable a lot more collaboration and a lot more seamless sign-on and seamless working. That is 100% target.
And regarding the PCN hub model, is there again, is it an aspiration, or is there a
There's an ambition, yes, Bill, in terms of that will be our target, to get to try and to have PCNs working at that scale with those hub modules, working in partnership with primary care colleagues in the CCG in terms of enabling that to happen.
Okay, I mean, and I would just like to add, from the County Council's point of view, we are very keen the care homes follow the digital roadmap, and that they sign up, and that is certainly, and when looking at how we purchase care, I can see that would become something that in the future would be a sort of a mandatory criteria over time, that care homes who are using our framework would have to have adopted it. And I don't have a timetable around that, but I'm keen that again, it's an ambition that in order for them to be on the framework, that they have completed that. So I suppose it would be interesting. I'm hoping to get some feedback in the County Council for a timeline for that. Hence my question around the questions within the CCG itself.
Sadie, did you want to come in with any of the? No, okay, that's fine. Move on to Rosemary.
Just really, hello Doris. I just wanted to echo Peter's point really about the cloud telephony, because certainly from some of the points that you've raised, Andrew, you know, as a large practice, well, yeah, the largest practice in South Norfolk, we've really struggled with our telephone system across 3 sites, and particularly at the moment when we have so many staff off with COVID, it makes it very difficult to man the phones. It's a real struggle. So the cloud telephony system that the CCG have been instrumental in putting together, we're really feeling sort of very, very positive about, because we've been looking to move to another company, and actually having some sort of CCG support behind that is actually going to be really helpful, because you're absolutely right, Andrew. I mean, one of the biggest bugbears is for patients getting through on the phone. It is a real challenge, and as a patient myself, I know how frustrating it is. So certainly that piece of work that the CCG has been helping with has been incredibly helpful.
Thank you, Rosemary. Tracy?
Yeah, I mean, I think sort of thinking from a perspective of working in primary care, the PCN hub approach is really going to make a difference, I think, to sort of practice resilience, because clearly being able to, book into shared clinics, work from different sites to another site. So if a practice, for instance, find one day due to sickness, they've got less staff, sharing roles and clinics, it just makes that resilience, I think, a lot better moving forward. So really keen we can progress that as much as we can. I just think we are obviously moving very much to kind of that digitalisation, and we must remember those that are digitally excluded and what's our approach and how we're going to support those people, because that will be an ongoing challenge for many. Thinking about that, and just my question about the NHS app, which may not be for everybody, certainly those that are digitally excluded, but we're still kind of 36%, which is quite low, and I use mine quite a lot, find it helpful for ordering prescriptions. You can make appointments on that, so we've got a target to raise it to 60%. How are we going to do that, and how do we compare to the rest of the country with our uptake of the NHS app? Because I think there'll be more functionality with that going forwards as well. I think there's planning for that to have more kind of provisions that we can use it for too. It might take some of the workload from primary care potentially.
Did you want to come back in on that, Pete?
Tracy, yes, that will be part of the plans aligned to national strategy. You are right, that will dovetail into part of that demand management and helping practices and PCNs with some of that demand management to look at not only obviously will it increase uptake, but what the payoff with uptake, which is some of those transactions that arguably are avoidable contact that you then have an impact on practice colleagues just to manage that contact could be done through pure digital means via self-service.
Thank you. Sadie?
Thank you, Doris. I just wanted to acknowledge some of the points that Andrew made, which also link with the previous item we discussed on access and the Health Overview and Scrutiny Committee report. I mean, obviously we've talked about the digital aspects on this item, but it links into a much broader issue of you know, the increasing demand on the urgent and emergency care system and workforce planning and workforce issues that we are working on. There clearly isn't a quick fix to any of this, but by trying to progress all of these different work streams, we are trying to improve the situation. And one of the other things that we're working on at the moment is trying to increase the depth and reach of our communications and engagement work with our colleagues in the communications team, recognising that you know, the situation isn't always as we might like it to be, but some of these issues are going to take a lot longer to resolve, and some of them are reliant on some of the national work that's happening too. But I suppose the good news, if there is any in all of this, is that Norfolk and Waveney practices do continue to offer about 70% of appointments face-to-face, which remains about 9% this last month's figures, but it's usually around 10% above the national average. And we are continuing to offer more appointments than ever before. And, you know, it fluctuates obviously month to month, but around 600,000 appointments are delivered every month in general practice. And we think that's probably under-reporting, because we know that there are various schemes in place which aren't necessary, and all the data isn't necessarily captured around appointments. So I think it's really important just to acknowledge that, you know, yes, we understand that there is continued dissatisfaction and that processes are not necessarily always meeting everybody's needs, but it is in the context of a much bigger picture and many streams of work around this. The Health Overview and Scrutiny Committee recognised that things weren't perfect, but there's a lot of work going on, and that work needs to be allowed to happen rather than us being asked to go back. I think they were satisfied that the work was ongoing and we didn't need to go and report back again, and hopefully the paper sort of set that out. But it doesn't take away from the difficult experiences that some people are encountering. And I think our comms and engagement work is really vital in making sure that people understand what clinical triage is, what it means, and what the different roles are, because it isn't just about seeing your GP and your nurse anymore. There's a really wide variety of workforce now working in general practice, and a lot of different ways into it, as Pete's described through the digital update as well. Thank you.
Thanks, Sadie. I think we've had a sort of good debate on the back of the digital on a wide agenda. So thank you, Pete, and back to Anne as well for the paper. And we look forward to hearing from you again when you next come and see us.
Lovely. Thank you very much, everyone.
Thank you. I'm going to move on to back onto the agenda, item 11 on the CQC updates. It's good to see that a number of practices are showing green, which is always a nice sign. So Shepherd, over to you.
Thank you, Doris. We have 3 reports since the last meeting, since last month, and it's for the Beccles medical practice, the Grove, and Churchill surgery. I'm so pleased that I'm reporting all green for the 3 practices. I won't spend a lot of time because it's all positive, but I think I'll take the report as read. So the Beccles, as you probably know, that it's a relatively big practice, and it covers about a population of about 20,000 people, families, and they've done really well to attain good across all the 5 domains, and so well done to them. I guess like any other situations where you do well, there will always be some areas where you would need to continue to work on, and I think easy access for patients and also continued work on patient satisfaction around surveys, and also alerts were identified in that. Moving on to the Grove, relatively medium size, 13,000 patients are on the list, and they have also achieved a good rating across all the domains. And I probably just want to pull out some of the best practice that was identified by CQC in that around training for staff in sign language. I know that there is a huge interest in the CCG around addressing inequalities, especially around for the deaf community, and wanted to just highlight that this is contributing towards those improvements. Again, in terms of areas of improvement around the patient engagement areas, to continue to work on that. Then some backlog kind of clinical issues, they need to continue to work on that. Moving on to Churchill. So Churchill, I think this is a remarkable position that we are in, given that this practice has been reported month on month for the last 7 months or 8 months. And now I'm really pleased to report that we have received the final report, and they have moved from inadequate to a good rating on overall good rating. 4 of the domains have been rated as good, with improvements in the well-led domain. And we are working quite closely with the practice in terms of continued improvements that are required. The external support, which is funded by the practice, is continuing until a point where they feel comfortable that they can carry on. And I wanted also to share with members the positive feedback that we received from CQC regarding this practice a few days ago, following a serious incident involving patient care, and the way they reacted to it and managed the situation. It was described as exemplary. So that is attesting to the hard work that has come from colleagues from CCG, CQC, the practice itself. So well done to the practice to get to this far. I will stop there, and if there are any questions, we'll be happy to take this.
Thank you, Shepherd. Chris.
Yeah, not necessarily a question, but just to pick up on that, Shepherd. So particularly with Churchill, they've done very, very well from a quality perspective. I know we were supported along with Shepherd's team and the locality team. But the practice manager, who I think was new at the time, has really sort of grasped it, really worked well with us, and I think the outcome is testament to their hard work. So they've done really well. And just on that incident, Shepherd, thanks for mentioning that. Yeah, they reported it to us really early. They gave us all the detail, everything we would have expected them to done. They had done, and the fact that they flagged it to us was really good, which I think just shows the open and transparent relationship we've got with that practice now. So they've really done very well in a short space of time.
Thanks, Chris. I'm particularly personally really pleased to see. I mean, to be honest, if you asked me before the report landed whether it would be good, I wouldn't have put money on it. And it's just such a turnaround in such a short space of time. And I think the team needs to be congratulated, and also the practice needs to be congratulated. I suppose I just, the sort of the more pessimistic side of me go, well, can this be sustained? And I suppose that's the, I think we need to encourage them to sustain the good practice for the benefit of their patients that they serve. So I would like to pass on, if the committee is happy for us to pass on our good wishes and well done, especially to that practice, because they've really, really turned the corner from where they were a few months ago. And obviously the CCG team for all the support they put in as well. Are there any other comments, questions from anybody for Shepherd? So you set the expectation quite high. So next time we're going to be expecting all green again.
No pressure.
But it's really, really good to see. Thank you. We'll move on to item 12, on to the interface report. I think, Mark, you're going to take us through this one.
Thank you, Doris. And I obviously won't do as good a job as Lois, but in her absence, I'll attempt to give you a brief synopsis. Obviously, I'll take the report as read, but actually really quite pleased around the spirit and nature of that meeting that's taking place. So we came here and Lois gave a brief update in October, which was very early days for the Interface Committee. So the positives are that we still have very good engagement, very good attendance across all providers. The LMC, Wendy from the LMC is a very active contributor, and it's great to have her there too. As the paper highlights, this was really an opportunity to really clarify the contractual roles across secondary and primary care, and try and tease out some of those interface issues that we were hearing about quite frequently. So I think the group have made some real progress. I think the biggest of those, as mentioned in the paper, is around the interface policy has now been signed off and agreed. So that was put forward in December. It went to all trust boards and has been signed off by all trusts across Norfolk and Waveney. So that's really good news. But I think if there's a negative, I think there is some frustration about the pace of some of what we're able to change here, but I think hopefully that will improve as we on our journey towards an ICB and ICS. I'm hoping we can pick up the pace, because actually much of this is about forming those relationships, having the honest conversations around what is working, what is not working, what it's looking like through the respective lenses. I think what's been really successful also is that everyone at that meeting are equal partners, so it's not just an opportunity for primary care to flag the concerns about some of the secondary care issues as they see them, but also for secondary care to flag any particular challenges. For example, referrals, and some of the referrals that have come through, some have been highlighted as perhaps could be a bit better. So it gives people an opportunity to pick those up. The paper does highlight some of the areas that we've worked on as an interface group, and some of these are kind of more longer term issues, but the other one that's not perhaps mentioned in the paper, it also gives members the opportunity to flag very live issues. For example, at the last meeting, given the pressures that we've got around ambulance performance at the moment, some of the practices were flagging that they're having exceptionally long waits when they are calling for an ambulance. So we're also able to be quite reactive as well as strategic in those meetings. So it's here just for information for the committee, but I think making good progress. Still much to do in the future, but I'm pleased with how things are progressing. And if everyone's happy to take questions, but we'll come back with another report in July to update you on some of the progress that's being made, if that's okay. Thanks, Doris.
Thanks, Mark. Are there questions for Mark on the paper? John?
Just a quick question, Mark, recognising what you said, that this is about building and enhancing relationships between the different sectors. Does there tend to be good representation from the relevant sectors at the group, so that hasn't waned, I suppose, as the group's got going?
No, and that's what I'm very pleased about, John. I think everyone recognises the value of the meeting, you know, and it's not just the 3 main acute hospitals and primary care. We've had really good engagement from the medical director and some clinical colleagues at the Mental Health Trust, community trusts, and so it really is a good forum to test some of that. So yeah, representation has been good and remains strong, but it's also, you know, it's also been a really good opportunity to bust some of the myths as well, actually, as a group. So yeah, and I think for that reason, as well as all the others outlined in the paper, John, yes, representation has been good.
Thank you.
Thank you. It's really good to see some progress. I suppose my worry is, you know, when you focus on contractual arrangements, the actual patient is forgotten. You know, the patient is lost between arguments, discussion, disagreement, whatever word you may wish to use, between organisations within the NHS that actually, frankly, as a patient, they don't really care because they want to be sorted out. And I think we can't lose that bigger picture in any conversations. Thank you. No other questions. I will. Oh, Mark, sorry.
Sorry, Doris, if I may come back just on that point, I completely agree. And actually what we found as the group, yes, it kind of started off on a contractual footing and we're dealing with a lot of those issues, but some of the issues that are being raised are more absolutely about patient experience, patient care. How do we make sure we improve those processes? So even though it started off as quite a contractual meeting, I'm very pleased to report that we're picking up some of the patient experience and also staff experience issues as well. So we mustn't lose sight of that. It's a really good point.
Yeah, it's just not allowing, you know, contracts, arrangements to dominate things that actually you can't actually get improvement in outcome and experience for both staff and for patients. So I'm pleased to hear that. If there's no other questions for Mark, we will move on to the estates paper. Paul magically appeared when I mentioned estates. Thank you, Paul. Take the paper as read and highlight, lowlights, whatever that's on the paper you want to bring our attention to. Thank you.
Nice. Yeah, so I've seen the papers read. 2 things I just really wanted to touch upon. The first one's the one around Wave 4B. I'm expecting some questions there related to the kind of the risk earlier on the agenda as well. So just to give a bit of a kind of an update on where we are with Wave 4B, we've had, and I have got a bit of feedback from NHS England, mainly the national team of NHS England, from our submission of the programme business case that was made on the 1st of December. That feedback does mean that we're going to have to rewrite elements of the programme business case, and we will need a resubmission, which means that the programme business case isn't going to be formed. We're not going to get a formal approval decision this month now, as we were previously expecting. And on resubmission, at the moment, the timeline we've been given from NHS England is that it's a 3 months approval process from us submitting it to then getting final sign-off from the Department of Health. There is a meeting happening today where they're trying to streamline that a bit, but that will be weeks rather than months to streamline that process. That is kind of out of our control, that approval process. What I would say is the feedback that we have received is actually really helpful and beneficial to improve the quality of the full business cases when we get there. It's just disappointing that we didn't have this feedback earlier in the process. NHS England have been cited on this, the regional arm of NHS England have been cited on this for several months, over a year now, and it would have been good to get that feedback earlier. So we are going to also had kind of good exec support from John and Tracy, who are fully cited on this. And as a CCG, we are going to do the works to rewrite those elements of the programme business case, get those submitted. But at the same time, we're going to commence on the full business cases at risk. We're going to have to do that because otherwise the end date of March 24, we're not going to achieve the bills by that point, and the 25 million allocation would be lost if we don't hit that end date. Again, NHS England are supportive of that approach. This means there's going to be a bit more of activity for my team and those to work on those projects over the coming months. So it's looking likely at the moment that the current timetable would be approval of the programme business case in September this year, and then the individual full business cases no later than December this year, which would give us 15 months to then deliver the schemes. We are briefing the governing body on this next week at the development session, and then picking up conversations with all practices involved in the Way 4B programme by the end of this month to kind of get them up to speed with timescales and how that impacts each individual practice. The next part of the paper I just wanted to touch upon is kind of the advice notes, in particular the note relating to increased space, which will have a rent reimbursement impact. The reason we've drafted this is over the last few months we've been contacted by approximately 70% of practices asking for increased space or submitting an expression of interest for a capital scheme which have an impact on increased revenue costs. So clearly we can't afford from our existing revenue budgets to fund all of those schemes, and we need a mechanism. We feel that we need a mechanism to prioritise those requests as they come in. The committee have already seen the process that's in place for capital requests, so this note is an attempt to put in something similar for revenue only requests. The LMC is cited on the process and are supportive, and we just welcome any comments from the committee before we kind of get the process completed and issued to practices. That's all I wanted to touch on the paper, but happy to take any questions.
Thanks, Paul. I'm sure there are questions, especially around the Way 4B. Fine.
Thanks, Doris. Paul, thanks for the update. And I did raise a question on the risk earlier, and John Ingham already provided some insight that you've built upon. As it's coming to the governing body anyway, maybe you can provide some assurance by way of pre-read in achieving that March 24 date if the full business case gets approved in December, because lots of supply chains are heavily affected, and I don't think it will magically disappear anytime soon. So maybe you can include some comfort how that is being managed. A quite specific question: in the risk register, it says you had received concerns raised about the proposed procurement route. Has that been resolved?
Yes, we had NHS England sought legal advice on our preferred procurement route, which contradicts the legal advice that we'd received independently. So as a CT, we decided we don't want to get into a legal dispute with NHS England, and we don't have the time to deliver the programme and resolve that. So we have explored alternative routes, and we have got a way forward. That will be included in the update to governing body next week.
Okay, thanks, Paul.
Bill. You're on mute, I think.
Sorry, there's always one, isn't there? I do apologise. Just on the issue of the primary care hubs, this is not something I've personally been involved in, but has there been discussion with local government estates on the siting of these with regards to land and sites. I just wondered, because obviously there is a program of localization of support on sort of social care as part of the prevention agenda, and I just wanted to make sure that that was part of the primary care hubs proposal.
All of the district councils and county councils are cited on cited on the hubs and the locations of the hubs. 2 of the 5 hubs are currently in local. I can't think of the right words. And currently in ownership by one of the local councils. And the other 3 are that they know the locations of those, so there's no surprises in there. In terms of getting increased social care elements of services provided within those hubs, that we've kind of missed the boat to expand on those as much as we perhaps would have wanted to in terms of the March 24 deadline. But all organisations were given an opportunity to kind of put in an expression of interest in terms of would like a presence in these buildings.
Okay, well, thanks very much. That's really helpful to know. Are
there any other comments from anybody? Andrew?
Yeah, Paul, can I just ask you, planning, at what level, or if at all in the CCG, do you interact with district councils as our planning authorities, so that when new housing is at the planning stage, do we have input to equate the health facilities with that? And then that, and also, for example, when there's a large change, like a large new care home being built in an area, and also whether that ties in with Section 106 money, which is the money that comes from developers to then use for potential practice building. I've never been clear, because this is a frequent question from the public, and I never know the answer. Where in the system do we integrate that? And usually nobody quite knows. Perhaps
we do have this has been a problem. I think it's been recognised a problem for the CCG for a period of time, and to address that, we do have a new team in post now. So the ICS Estates team, this forms part of their responsibilities. So there's a dedicated planning post within that team. They respond to all planning applications that we receive. We do receive a large number of planning applications for comment, and the role of that team is to kind of they'll provide one response for the basis of health. So they'll look at it from a primary care perspective and from an NHS Trust perspective. So from a primary care perspective, they'll come to me and my team, and depending upon the size of the application or where that application is, we may need to speak to the practice, the nearest practice to that site. But a lot of the time, we don't need to, and we can do that without dialogue with practice. But in other instances, we will need dialogue. So the idea being that the planning authority then gets one view of all health needs, which will then there's a pound amount normally attached to that, asking for a Section 106 contribution.
Does that help you, Andrew?
Yeah, thank you. I didn't realise there was a specific team now that's been established. That would be great to find out where that is. Thank you.
They have only been in post a couple of months, so they are quite new.
Thanks.
Thank you. On the paper where you're talking about actual space requirements, especially with the additional roles that have been implemented, I assume that the estimate of space is actually an underestimate, because it doesn't take account of some of those role requirements. So is there, on a long-term basis, there's going to be more pressure on the ICS going forward in terms of both capital and revenue funding?
Yeah, so the tables presented in the paper showing kind of our estimates of over and under GMS services only, and don't include the R's roles. So there would be an additional pressure on those. That's hard. It's hard to calculate the size of that. Different PCNs have taken slightly different approaches to how they'll house and what space they need for those roles. But that's something that we do need to explore further. The consistent message we're getting from NHS England at the moment is should be maximising all kind of existing utilisation, which makes sense, and we're doing that. We're doing that the best we can, but I think the table kind of evidences that that's not an option in some areas in the county, and we are going to have state pressures regardless of if efficiency savings could be productivity can be improved and elsewhere in the county.
Thank you. Are there any other comments, questions before? No, so thanks for that update, and we look forward to more information in the governing body next week as well. Thank you. Not next week, 2 weeks' time.
Thank you.
So move on to the prescribing report. Michael.
Okay, so yeah, thanks, Doris. I'll take the paper as read. So first section is our usual section on finances and the sort of nuanced aspects of costs and variations in category M, etc. I won't dwell on that so much. Dependence forming medicines, not much movement on that this time, which is a double-edged sword, but certainly we're remaining at third position. I did commit many months ago to saying that when we got to January data, we might have dropped a position, but we haven't, because everybody else is also dropping down at the same time. And if you look at the chart on just before section 4, you can see we are dropping at a rate which is faster than national. So we certainly will be dropping down some positions in the coming months. Certainly by the next 6 months, I would be very surprised if we haven't dropped a couple of positions on that one. As Chris has asked for a bit more detail, perhaps on some of the actions that we're taking, I'll put in the next report and put in the risk report as well. We're working quite closely with UEA on their opioid toolkit, and also with the Academic Health and Science Network, and our GP prescribing advisor Andy Douglas chairs a regular weekly meeting on opioids and drugs of dependence forming medicines. So we are doing quite a lot of work. I'm perhaps not shouting about it enough as I should. We had planned a stakeholder meeting earlier in the year, but we had to cancel that at short notice because most of the GPs weren't actually able to turn up in the end. So we are going to turn one of our prescribing leads meetings into a focused meeting on dependence forming medicines as part of the PQS that we will hope to launch fairly soon, because those are key cost saving and safety improving measures within that work. Antibiotics, little bit of movement on that. We've got a slight worsening in volume, but only a very small one in January data. A slight improvement in percentage of broad spectrum antibiotics, and one of our clinical pharmacists has been working with some of our outliers, and the ones that she's been working with have improved quite significantly and will continue to improve. We're in the process of trying to get into some of our higher outliers at the moment, and we'll report back on whether they've let us perhaps do some basic audits. We're sort of reaching out in a fairly positive manner, encouraging them that, you know, us doing audits and helpfully pointing out some action points is useful for their CQC rating, etc. But we sometimes struggle to get into some of those practices for various historic reasons. Just a very brief covering of self-care we thought we'd mention. So we're focusing on 3 aspects of self-care this year. We've already launched Don't Get Caught Out this spring season with hay fever, and we've also launched a self-care message as part of the Easter pressures, and pharmacies are open, and please make sure you have sufficient of your own medicines, etc., and some self-care medicines and we'll shortly be launching further items in that area. So next month I'll cover in more detail some of the DFM work that we're doing, dependence forming medicines. I'm happy to take questions, comments.
Thank you, Michael. Yes, let's hope you get into all practices, because actually it's for the benefit of patients. You know, the costs to me is almost secondary. Is actually that's the bonus bit for in improving prescribing. Any questions, Michael? And I think the where you're having resistance, you know, don't feel that you can't shout if you need us to do something a bit more muscular. I'm sure from the committee to do so.
Thank you.
Thank you. Moving on, last but not least, finance. Thanks, James, for hanging on in there for the whole session. Over to you.
Thanks, Doris. Yep, so as usual, I'll take the report as read, but highlight the key points in the report to you and also clarify some of those points. The executive summary you can see is at month 11. The total year-to-date primary care and prescribing budgets are 1.2 million adverse to budget. The full year forecast adverse variance to budget is 3.2 million. However, this does include 1.3 million of additional winter access funding and 1.7 million of additional ARRS funding to be received. With this factored in, the forecast is net it will be 0.3 million adverse to plan. Moving on to the financial summary, this shows that GP prescribing deteriorated by 2.3 million from month 10 to month 11. With the figures being 2 months in arrears, this is an undervaluation of the December estimate. In addition, efficiency savings have not materialised in this period, putting pressure on the forecast with efficiency expectations already baked into our budgets. The prescribing efficiency forecast has been revised down in the month 11 position in order that the current achievement can be reflected. This reduces from 2.5 million for the half two original efficiency requirement to 1.1 million. The 2.3 million movement also includes a reduction in recharge and rebate income and the existing cost pressures previously reported around CSU in housing and dressings. Delegated primary care has increased considerably due to additional role reimbursement costs of 1.7 million, but as stated, this comes with additional funding. Moving on to the detailed finance analysis, this shows the key drivers behind the prescribing overspend of 4.5 million against budget and some of the areas attempting to mitigate this. Then moving into the specific funding areas, so the System Development Fund, this key area of investment is still showing predominantly on plan with a few small favourable variances to budget. Then into delegated co-commissioning, the same favourable variances are showing here in terms of the Norwich APMS contract. Favourable rent revaluations offset by the existing pressure of QOF of the indicators passed from to the CCG from NHS England at the beginning of the year. There is also a significant prior year accrual release within delegated. In addition, there's £3 million worth of WAF and Rs costs which are predicted to be spent with no current budget. However, as stressed before, the retrospective allocation is to be received from NHS England to offset and that has been received in the month 12 position. The additional WAF and Rs income is forecast to be fully spent in the month 12 position. Moving on to GP and other prescribing, the total variance of 4.5 million includes a prior year release of 1.78. So the underlying variance within this prior year benefit is excluded to give 6.28 million underlying variance. This is being driven by the growing diet pressures, COVID-related prescribing, and lower than expected efficiency achievement, with additional pressures from dressings and oxygen. That was all my key points. If anybody has any questions.
Thanks, James. Are there any questions for James? John.
Question for Michael, actually. So the comment there in terms of prescribing, obviously one of the elements that makes up that variance is the slippages we've had, the inability to be able to progress the efficiency savings for very good reasons during the pandemic, etc. just looking ahead, Michael, in terms of starting a new financial year, we're now 12 days into 22-23. Do you feel that that's changed sufficiently that we're able to have a good focus on efficiency and productivity going forwards?
Has it changed? It's at the moment, probably not precisely at this moment, but I'm thinking, well, it has to improve in the next month or two, doesn't it? Surely the COVID cases should be coming down, and practices should have a little bit of headspace for us to provide some support for them to make some changes, either through their their own PCN pharmacy teams or what support we can provide. And we have some plans which are in the scheme, the Optum switches, for instance, which we're looking at, where we can provide do remote support to do some of that switch work without involving practice time. So plans are in place, and some of the things that came out with the updated QOF indicators in terms of opiate work plans and the IIF schemes very much aligned with some of the stuff that we're proposing to do. So there's certainly a focus on some of the high spending areas in terms of DOACs and opioids and greener inhalers, etc. So I think all the incentives are there. It's just getting that practice headspace, which some of the practice colleagues on this call will be able to say whether things will be in a position that either they can deliver with a bit of support, or we can provide more hands-on support for those practices that need it. I'd be looking to my primary care colleagues just to say, whether you think you're going to emerge from the current firefighting situation any day soon. What do people think? I mean, my feeling is that it will certainly happen in the coming weeks, but to a limited extent, and then we can get back to what was business as usual before this came along.
Rosemary?
I do hope so.
Yes, I think we're all hoping so.
All I can really say to that one, it's
I know.
funny actually, Mike. In the last 6-week period, we've actually had more staff absences in one lump sum than we've had in the whole 2-year period. Staff off with COVID, not extremely poorly, but still off. So in actual fact, from an actual operational viewpoint, it's actually been worse, I think, probably the last 6 weeks, because obviously we're coping with increased demand at the same time. Yeah. Whereas before, during, when we had staff off, we were either in periods of lockdown, and I said the demand was not there. But, we're now moving forward. We're certainly planning for things, business as usual, as much as picking up with all the work that we had previously put on hold. So we're very much looking as primary care to get back to what we were doing up to 2 years ago. So hopefully.
Well, so are we. Certainly, I think that is perhaps the answer to John. That we are all hoping that it's going to improve significantly, but it may not be any day soon.
I've got very wary of predicting anything just at the moment. So yeah. I'm not fingers crossed. We're doing all we can.
Thank you, Rosemary. Maybe somebody knows a magic Easter bunny who brings, fantastic chocolate eggs that will solve our problems. But I think that's wishful thinking on my part. So thank you. If there's no other questions, are there any questions from the public that's come in, Sarah, whilst we've been gathering? Oh, Bill.
It's not a question as such. I was just mulling on that figure of 600,000 appointments per month out of a population of just over 1 million. And that's probably an underreporting, which seems to me an astonishingly high number given our population. And I just wonder if that was broadly comparable with any of our sort of systems around. And are we an outlier, or is this? And if we are, I'd be quite interested, because it might be a discussion we could have with Region. But if we're not, then we don't need to bring it up at Region. But I just wondered if there was any sort of comparison, the levels of demand? Because it's not a figure I'd heard before. It was mentioned today.
Sadie, did you want to come in?
Yeah, I don't think I can with confidence answer that question. I'd need to go away and have a little look at the data, but certainly we are in common with everywhere else in terms of rising demand compared to 2 years ago. And a little stat I heard the other day was around, going back 2 or 3 years, the average patient consulted their GP practice 6 times, whereas now it's more like 12 times. And yet, workforce wise, we're seeing some real challenges, which leads to people working so much harder, such longer hours, and trying to carve up the work in a different way. But I think it's a good question, Bill, and we will just go and check to see if there are any differences in that data that we can get, or whether it is something that we need to ask the regional team. Thank you.
Thanks, Sadie. Are there any questions from the public, Sarah, that we're aware of?
No.
Thank you very much. Well, I've hit dead on 3:30. So for those who I'm not going to see again in the next meeting after this, I hope you all have a good Easter and look forward to seeing you in May. And for those who have the misfortune of having to come back, shall we have a 10-minute break so that you can get some refreshment and have a little run around? Thank you.
Thank you.
Thanks.